Hello, class. Today we are presenting on our project, which is an evaluation of the history-taking tool HOUSED. This project was inspired by our experience during our clinical rotations with USC Street Med and Clínica Romero, a local FQHC that many of us have rotated at. So why is this important? During our rotations, we learned that FQHCs serve a high number of patients experiencing homelessness, creating a need for shared approaches that support consistent, patient-centered conversations around housing. Many unhoused patients rely on FQHCs, and their visits require consistent conversations about housing. These conversations about housing and related needs can be complex and time-limited, and providers benefit from tools that help structure these discussions efficiently and respectfully. So in 2019, a tool was developed and published by the USC Street Medicine team called HOUSED, which presents an opportunity to support providers and care teams by offering a common language that enhances communication, coordination, and trust with patients. It utilizes a mnemonic to streamline history taking and ensure thorough questioning for providers, while enhancing communication with unhoused patients. On an interprofessional level, it promotes a shared language across providers and social work, strengthening team communication and care coordination. For unhoused patients, it enhances patient trust and engagement by normalizing housing discussions within routine clinical care and supports early identification of housing-related barriers that can inform follow-up planning and referrals. Overall, the goal is to help care teams respond proactively rather than reactively. Next, we're going to go into some of the evidence to support this project.
Okay, so for research shows that tailored, structured approaches to care for people experiencing homelessness lead to better patient experiences, supporting the use of tools designed specifically for this population. Multiple reviews and studies highlight that while screening tools for housing instability are generally well accepted by patients and providers, many existing tools are limited and do not fully capture the patient's lived experience or history. Furthermore, providers recognize the importance of addressing housing as a health issue and report mixed comfort and role clarity, underscoring the need for practical team-based tools like house beds that support, not burden, clinical care. We believe that house beds can fulfill these gaps as it provides cognitive simplicity as a memorable mnemonic, reduces mental load, helping providers ask comprehensive questions quickly and consistently, even in time-limited visits. It also provides a shared language using the same framework across medical and social work teams, aligns communication, supports interdisciplinary huddles, and streamlines care planning. Furthermore, it creates trust with patients through structure, normalizing housing-related questions within a routine framework signals respect and reducing stigma, making patients more comfortable sharing critical information. So our plan was to introduce providers to house beds by hosting a brief lunch and learn for healthcare providers at the FQHC. It would include its purpose, structure, and relevance to patient care. At the Lunch and Learn, we provided simple handouts with the house beds mnemonic and sample questions to support easy use during clinical visits. And to evaluate the effectiveness of the intervention, we conducted a brief pre- and post-session survey to assess familiarity, comfort, and perceived feasibility of using house beds in clinical practice. And now we'll pass it on to Teresa.
Thank you, Shay. So in terms of health literacy, cultural humility, trauma-informed practices, equity and inclusion and advocacy, the HouseBeds intervention standardizes complex housing-related questions to create a common language accessible for patients, providers, improving health literacy. In terms of cultural humility, it's central to the tool's design as it encourages providers to approach each patient's housing situation without assumptions, acknowledging that homelessness is a lived experience. The framework approaches this delicate topic using a trauma-informed lens by normalizing housing discussions within routine clinical care, reducing stigma, and allowing patients to answer open-endedly. In terms of equity inclusion, these were addressed by investigating the utility of this tool in an FQHC setting, targeting a health disparity that disproportionately impacts some populations more than others. And finally, The house beds intervention incorporates advocacy by equipping medical providers with practical tools to identify patients experiencing housing instability and connecting them to appropriate resources. Now we'll move on to Chris for the results.
Thank you, Teresa. So let's take a look at some of the numbers. So a total of 7 participants completed the pretest survey and 6 participants completed the post-test survey. Respondents represented a diverse interprofessional group of physicians, nurse practitioners, physician assistants, an optometrist, a student, and a front office supervisor. At baseline, 71% of participants were unfamiliar or very unfamiliar with the house beds tool. Post-intervention, 100% of respondents indicated they plan to use house beds, demonstrating successful knowledge transfer and perceived utility of the tool. Confidence improved markedly after the intervention. Pre-test, 57% of respondents reported neutral confidence, while post-test, 100% reported feeling either confident or very confident. Moving on to the next slide. So pre-intervention, no participants felt very ready to respond if a patient reported lacking safe housing. Post-intervention, 33% felt very ready, and no participants reported feeling not ready, indicating improved preparedness to act on positive screens. Post-intervention, 100% of participants correctly identified the appropriate use case for house beds compared to 71% at baseline. Time constraints remain the most cited barrier both pre and post-intervention. So taking a look to see how our outcomes stack up with the objectives, our first objective to increase knowledge of house beds tool by at least 80%. Pre-test, we had 29% familiar, and post-test, we had 100% familiar. Our second objective, to correctly identify when and how to use the tool, we targeted a 90%. In pre-test, we achieved 71%, whereas a post-test, it was 100% correct. Our third objective, increasing confidence in screening for homelessness, we targeted 75%. In pre-test, we had 29% confident, 14% very confident, and 57% neutral. And in post-test, we had 67% confident, 33% very confident, and 0% neutral. Our fourth objective was the intention to incorporate the tool into routine screening, targeting 80%. We did not ask this in our pretest, but in our post-test, 100% said yes. So our key takeaways are that our intervention moved providers from uncertainty to confidence, from 57% neutral to 100% confident/very confident. We reduced knowledge-based barriers, concerned about not knowing what to say, and opening hard topics were reduced to 0. Time remains a systematic challenge. This requires organizational solutions beyond education alone, such as workflow integration and EMR dot phrases. 100% adoption intent demonstrates feasibility. Every participant plans on using the tool, which suggests it could be a useful tool. But this is not perfect. Next, I'm going to pass the mic to Jasmine to talk about some of the limitations.
Thank you, Chris. Although our intervention yielded promising results as discussed by Chris, our intervention had several limitations that can inform recommendations for future projects. First, the pretest assessed self-reported familiarity rather than objective knowledge. Future studies should include knowledge-based questions requiring participants to demonstrate their understanding, such as using multiple choice items, asking providers to identify what each letter in HOUSED acronym represents. Second, the post-test measured general intent rather than actionable behavioral change. A simple yes/no question about planning to use a tool does not capture meaningful commitment. A follow-up could be done to assess if providers actually use the tools at 3 months. Incorporating SMART goal framework would prompt providers to implement this tool in a more active way. Third, our sample size was limited. We had 7 participants for our pre-test and 6 participants for our post-test, with 1 respondent lost to follow-up, limiting the generalizability and statistical power of our intervention.
Thank you, Jazz. So, in conclusion, our intervention was successful in several ways. Our first strength was that our location, Clínica Romero, and target population of our intervention was very appropriate for our group's goals. The feedback we received was that Clínica Romero has a very high unhoused patient population and that our house bed tool could be utilized in multiple specialties at the clinic, such as women's health, family medicine, and their street medicine teams. The intervention was aligned with the clinic's mission of addressing the mental and physical needs of their patients while also streamlining access to other resources that the clinic offers. Clinicians also commented that the clinic did not have a formal strategy for history taking and that the housed beds tool was a useful idea. Our second strength was that our tool was easily actionable for clinicians. We included multiple ways to incorporate the housed bed tool, such as providing handheld printable flyers, providing examples of EMR utilization of the tool, and sending follow-up emails with example dot phrases for the clinicians to access. This ensured that the tool could be used beyond our presentation. However, one aspect that we wish we could have improved on is assessing the Clínica Romero provider's actual knowledge rather than perceived knowledge of the house bed screening tool. Our original question assessed self-reported familiarity rather than actual understanding. So in the future, we would incorporate objective knowledge-based questions to better evaluate learning outcomes and the effectiveness of our intervention. Similarly, we wish we could have improved how we measured behavioral intent after the intervention. Instead of a simple yes or no question, we would incorporate a SMART goal in our post-test survey to have participants create a specific, measurable plan for using house beds in their practice, allowing us to better assess true behavior change and implementation readiness. Additionally, it is important to note that housed beds is not currently a clinically validated tool. More research is needed to investigate the effectiveness of this tool prior to widespread use.
So right now, healthcare providers are missing over 70% of patients experiencing homelessness because we do not have a consistent way to ask.
A 2024 JAMA Network Open study found that standard diagnostic codes for housing instability have only 28% sensitivity, suggesting that the vast majority of unhoused patients go unidentified in our health systems. But there is a solution already tested and ready to use: house beds, a simple mnemonic that transforms how we talk about housing and clinical care. It takes less than 5 minutes to learn. It can be used in time-limited visits, and it gives medical teams and social workers a shared language that builds trust with patients and allows documentation to improve follow-up of social health needs at future encounters. When we piloted this tool at one local FQHC, Clínica Romero providers reported they are better equipped to take a social history to screen for homelessness and are more likely to connect patients with the appropriate resources. How many more patients can we identify and help through the dissemination of this tool? Imagine the impact on over 1,300 FQHCs nationwide. The evidence is clear. Structured approaches work, patients benefit when we ask, and providers need practical tools to support rather than burden their workflow. House beds might just be that tool. So let's make housing conversations as routine as vital signs, because housing is healthcare, and every patient deserves a provider who knows how to ask.
Just wanted to acknowledge USC P8 Pathways, and special thanks to Liz Padilla for helping support the lunch portion of this educational event. This would not be possible without all of their help. So thank you so much.